She has published more than 40 scientific and medical papers in international journals and has also delivered over 60 lectures on variety of subjects in the field. So, Dr. Maria is going to talk to us about the innovative use of artificial intelligence in the skin rejuvenation. تفضلي دكتورة.
Thank you, Dr. Jihan. Good morning, everyone. Yes, so this is my talk this morning about AI in skin rejuvenation, and these are my disclosures. There is no doubt that actually smooth, flawless skin is integral to female beauty. And what do we mean? And this is across the board in women of all ethnicities. Basically, skin qualities such as uniform color, uniform texture, firmness, and glow. What happens is that the skin is smooth, it acts like a mirror, so incident light gets reflected, and the onlooker perceives it as radiant skin. So how do we achieve a youthful appearance in patients like these? Basically, no amount of filler, booster, toxin, or even a surgical facelift is going to restore their youthful glow. We need to improve skin quality. It's one of the most integral things in beauty. And of course, we have a plethora of devices, lasers and energy-based devices at our disposal to do all of that. And the IPL, or pulsed light, broadband light, are one of these non-ablative systems. So why should we be offering these effective broadband light systems in our practice? First of all, it's a zero downtime treatment, making for patient compliance. And as the patients comply, they will get better results and you will be perceived with good treatment outcomes. Secondly, we have very solid evidence, which I will present now, in terms of the anti-aging effect of this device. Thirdly, we can restore skin health, and it's ideal in prejuvenation as we have more and more young patients availing of treatments that as they know that they will delay aging. So broadband light emits the full spectrum of wavelengths from UV 400 up to the mid-infrared range of 1200 nanometers. So the different wavelengths will therefore penetrate to different layers of the skin, targeting melanin and hemoglobin, and that's why they're very powerful in removing skin dyschromias, ultimately leading to healthier skin. So the mechanism of action is twofold in terms of skin radiance and rejuvenation. First, by removing these dyschromias, we can treat things like poikiloderma of Sivat, solar lentiginous, telangiectasia. Secondly, the mid-infrared wavelengths and the near-infrared wavelengths will give a kind of wounding to the skin and are very effective in treating fine lines and wrinkles and solar elastosis. Because the thermal injury, which results in temperatures of about 40 to 50 degrees, will induce an inflammatory response due to the release of heat shock proteins and ultimately lead to thickening of the skin. One cannot talk about the use of pulsed light in skin rejuvenation without mentioning Dr. Patrick Bitter, who did the pivotal studies on how pulsed light can rejuvenate the skin, and he called the treatment a photofacial. The first publication way back in 2000 looked at using the system in a stationary mode, emitting pulses of about 30 to 50 joules per square centimeter, which is quite high, to treat the skin. And this is conventional pulsed light therapy. Stationary treatment on the face, maybe 2 passes or 3 passes. But what he could show was not only the clinical improvement of the skin, but on histology, he could show very good rejuvenation in terms of the dense collagen deposition and restoration of the wavy pattern of the dermo-epidermal junction. And he went on to prove that we can actually reverse skin aging with broadband light, and develop the Forever Young protocol, whereby the treatments are monthly for 5 months, and then patients have to maintain the results by at least 3 to 4 annual treatments. And the results were published whereby patients were followed up for up to 10 years, And constantly we could see, and these are from his publications, his images showing 32 treatments over 10 years, and this patient went from age 38 to 49, looking younger and more refreshed. Here too, age 39 to 49, again looking much better after a total of 36 treatments in 10 years. So nobody gets better with time, and these patients had only had broadband light treatments and nothing else. Again here and here, 43 to 55 after 11 years, looking much better. Now, he went on to do a study in conjunction with Stanford University Human Genomics Lab, whereby 5 older women over the age of 50 with moderate to severe photo damage were treated on their forearms. So only part of the forearm was treated and another part was a control, it was occluded. Then they looked, of course, at histology and they looked at gene expression and compared it to women of 30 years of age. So you can see in the dashed line the treated area, I don't know if this is working, and the occluded line, the area was the one that was not treated. Of course, the treated skin definitely looked clinically better, less wrinkled, less pigmented, but that wasn't the point. Only on histology there was a reduction in elastosis, more dense and uniform collagen fiber deposition in each case. However, what was really interesting and pivotal was the fact that normally skin aging is associated with an altered expression of about 2,265 genes. Half of those were rejuvenated. So the light is doing something to delay aging and reverse aging at a genetic level. So this is very profound evidence, and we can therefore recommend these treatments to our patients from a point of solid science. And the fact is that the skin looks healthier years after. It can, the more treatment one does, the better is the outcome, and ultimately you can use it anywhere on the body. Now, we all feel that conventional pulsed light therapy is dangerous for darker skin types. This is our thinking. Definitely, we cannot use it in skin type 6, that's a fact. But even 4 and 5, we are apprehensive generally and very conscious with conventional pulsed light treatments, because as we saw, the treatments use energies of up to 50 joules to be able to get a certain endpoint. And the other thing is that the handpiece is manually controlled. So you can have areas of pulse stacking or skip areas. So you can have either inadequate treatment or over-treatment. You can have side effects like these, PIH, due to the fact that the control is sometimes not consistent depending on the practitioner. So where does this artificial intelligence come in? Basically, the AI-controlled BBL gives us literally a new standard, because we can deliver very low fluences, down to even 2 joules per square centimeter, but repeatedly treating the skin and building up a cumulative energy in the skin. This is only possible because the treatment can be done in motion. It's very fast. And there is a special skin positioning system, AI-controlled placement of the handpiece. So first of all, the BBL itself is a dual lamp technology, and it allows for very quick changes of filters. The spot size is large, 6.7 centimeter. However, it has a uniform delivery of energy, what we call a flat top beam, and it has a very good and strong cooling system, which of course reduces the risk of burns. We have the smart filters, which can be changed on the fly. Basically, you don't have to switch off the device. You take off one filter, put in the other filter, which is appropriate for the lesion you are trying to treat. And of course, all of these indications we know are part of the indications for pulse light treatment, flushing, rosacea. You can treat acne, skin tightening. It's very powerful. And again, on the fly, without switching off the device, you can put on a clip-on magnetic spot adapter. So you can change the spot size as you go along. So the small spot sizes are very useful, for example, let's say to treat small vascular lesions, small pigmented lesions with a higher fluence without affecting the rest of the skin, and also extremely useful for patch testing. So we see here, for example, in our patient with skin type 4, and typically we would be very cautious with her, treating the whole face and neck around the eyes within 10 to 15 minutes at a 5 joules per square centimeter using the 560 nanometer filter, pulse duration 4. So you see, the energy used is very low. So it's very comfortable for the patient. They don't get, this kind of recoil when you treat them with the normal BBL. So, and you're consistently delivering hundreds and hundreds of pulses. Sometimes we deliver up to 2,000 pulses. So all this cumulative energy has a huge benefit in the skin. Décolletage within 2 minutes, full arms, fingers, hands with a small spot size, again, in no time. So the skin positioning system allows real-time coordination between the handpiece and the brain of the device. And it has also a rotation matrix to treat around the curve. So as you're going around the curves, it's also detecting that all the time. And the intelligence console is actually the brain that gives you spatial data and follows the movement of the operator. As the operator is going fast, it will fire quickly. When you stop, it will stop firing. And we can see here, we used a thermal camera. You can see how the pulses are stacked properly, how you can set the overlap. In this case, it was a 20% overlap. There are no skip areas, and there is no double stacking. Now, a nice histology, this is preliminary study done by Dr. Chris Robb, looking at histology 3 months after one session. It's quite dramatic in terms of the dense collagen deposition and also in terms of the elastin fibers. So imagine what happens after a series of treatments. So for now, some of our results is absolutely integral to our protocol for the treatment of rosacea.
Doctor, you have 3 minutes.
Yes, I'm almost done. We can see here before and after 4 sessions, nice improvement. Again, you can see her profile. Here also this patient had very bad erythemotelangiectatic rosacea after a series of 5 sessions. And of course, we know rosacea is chronic, so they need obviously their maintenance treatments, but they all want to avail of this treatment anyhow because especially the women, we make them, educate them about the anti-aging effect of BBL. So for solar lentiginous, after a single treatment immediately, and again with subsurface illumination, we can see that the pigment is completely eliminated in the lentiginous. And here we have, again, rejuvenation after 3 sessions. So the results are very, very swiftly seen. And this patient, of course, definitely she's a patient for resurfacing, but she totally refused to have any resurfacing. And the reason I show her like this is that she is not smiling. So this is not a case of Botox. These are stationary lines. And this is her after 4 treatment sessions. Actually, we were shocked by the fact that we could treat these wrinkles only with BBL after 4 sessions. For dark circles, everybody's talking about dark circles. Of course, we know various etiologies of dark circles. This is after 3 sessions. We have dermal thickening, which conceals the vasculature, which gives you a nice brightening and firming effect of the skin around the eyes in each case. So AI-controlled BBL should be an integral part of any regenerative aesthetic protocol. Thank you.
Thank you, Doctora. Thank you very much. And now, Dr. Maria will talk to us again about the pivotal role of polyl-lactic acid in regenerative aesthetics. Tfadal, Doctor.
Yes, you will upload it. So my next talk is about polyl-lactic acid. and the integral role it has in regenerative aesthetics again. And as we know now, the days of over-pumping, over-treating are over. We're all into regeneration. Again, my disclosure, we know that poly-L-lactic acid is totally biodegradable and biocompatible alpha-hydroxy acid synthesized from lactic acid and is totally broken down. And there is a world of science backing the use of PLLA. Now we know that the appearance of skin is integral on the health of all layers of the skin, of course the epidermis, dermis, the hypodermis, and we know that the structural integrity of the skin is to a great extent dependent upon the levels of collagen and elastin, especially type 1 collagen. Now, we know also that aging is associated with a reduction in collagen as of the age of 21% per year. By the age of 45, we have 25% decrease in collagen levels in the skin. This is compounded nowadays because we are living in an era of rapid weight loss. So we have all these patients availing of the GLP-1 and GIP agonists that are losing weight quickly, and of course is beginning to show on the skin. So it's even more critical for us to try and improve the skin in these patients. Of course, again, with time, we have accumulation of abnormal elastin, resulting in a decrease in firmness, thickness, and elasticity of the skin. And a new concept that we're talking more and more about is skin-associated adipose tissue. We have two types of white adipose tissue in the skin: dermal white adipose tissue and subcutaneous adipose tissue. Adipose tissue is a reservoir of stem cells. So it is what helps us regenerate, and that's one of the reasons why we see accelerated aging in patients that are losing weight very quickly. So both aging and rapid weight loss reduce the adipose tissue in the skin, and therefore the structure and the appearance changes. So PLLA is actually the first proven regenerative biostimulator, and this is what I will show now in terms of how it works. If we look at its mechanism of action, first of all, we have the microparticles that trigger an initial inflammatory response, a localized response, and what happens, macrophages come to try and engulf the PLLA particles, which are too large to be engulfed. And the type of the macrophages that are activated are of the M2 type, and this has been shown recently. What happens, therefore, you have the fusion of these macrophages to form foreign body giant cells that then release cytokines and activate senescent fibroblasts and cause proliferation of the fibroblast. So this results in production of type 1 collagen and elastin, proteoglycans and laminin, which start signaling between the dermis and hypodermis, and you have transformation of adipocyte progenitors into mature adipocytes. All of this resulting in thicker, healthier skin. So this is the recent publication talking about the two phenotypes of macrophages, and it's the M2 macrophages that are activated by PLLA particles. So how does this regeneration occur? Either direct stimulation of the native stem cells or indirectly by modulating gene expression. And only last year, a study done by Weibel and her colleagues looked at the expression of genes after patients were injected with either PLLA or the competing biostimulant calcium hydroxylapatite. So they took biopsies from the nasolabial fold of patients treated before treatment and after treatment, after 2 treatments with either PLLA or calcium hydroxylapatite. What they found was really quite interesting. Basically, PLLA codes for ELN gene, which ends up in the induction of tropoelastin and elastin. And it's important to note that elastin can only be synthesized in an environment of low inflammation. Secondly, DKK1, which regulates skin pigmentation and thickness, HGF, which stimulates stem cell differentiation, and MT1A, which has antioxidant activity. So basically, all of the genes coded by PLLA are either stimulating the formation of the extracellular matrix, wound healing, or antioxidant activity. Conversely, gene expression by calcium hydroxylapatite coded for IFNA1, which is a cytokine that regulates immune function and mediates tissue inflammation. It is associated with organ damage, and it is actually activated in several autoimmune diseases. MMP9 is used also as a biomarker for chronic inflammation. So there's completely different gene expression by PLLA and calcium hydroxylapatite. Most of the genes here are of the inflammatory type. So we know that biostimulation in our thinking is indicative of collagen formation, and both do induce collagen, but it doesn't stop there. Regenerative aesthetics deals with the formation of the other components of the extracellular matrix. And we can see with PLLA, no inflammation after 3 months, type 1 collagen formation, and has an overall regenerative pathway. A second study by Weibel and her colleagues looked at gene expression to do with adipocyte modulation and found that PLLA, only PLLA, and not calcium hydroxylapatite, regulated the genes to do with adipocyte biomodulation. This is a study by Fabi showing also increase in elastin up to 34%. And again, we can see on histology the effect of PLLA on elastin. And of course, the effect on type 1 collagen has long been known, up to 66% of type 1 collagen at 3 months. Skin thickness also has been shown to increase, and this is due to the increase in dermal white adipose cells. Of course, there could be a direct action also in stimulating the stem cells in the fat and therefore resulting in regeneration of the adipocytes. So basically, in summary, we have 66% increase in type 1 collagen, 34% elastin, and 26% increase in skin thickness. So the major concerns of patients, whether it's aging patients or rapid weight loss patients, to do with lack of skin radiance, to do with loss of volume, and to do with a lifting effect or firming of the skin can be addressed depending on how the treatment is done. So this is very contingent on how the treatment is performed. We have certain controversies regarding the use of PLLA. We have a lot of talk that especially from the surgeons, that you cannot use PLLA if you're going to go for a facelift. It's going to act like glue, all kinds of unsubstantiated and without any evidence. Now, there are no publications to prove that. However, there's one publication 2 years ago by Dr. O'Daniel, who's a plastic surgeon, and I actually communicated with him about this. He looked at 241 patients who had undergone facelifting and fat grafting, because obviously in an older woman, most of the time they need volume, so fat grafting is indicated during the facelift procedure. 51 of these had received PLLA prior to the surgery, and 190 received PLLA post-surgery. So he found that PLLA is safe either before or after facelift surgery. So that puts to rest all of these rumors. And if you see, because it's a well-known fact that fat grafting is not always predictable, that we cannot guarantee that the volume will be sustained. So basically, this is a 71-year-old patient before facelift with fat grafting, and then 1 year after facelift and fat grafting in the middle, but before PLLA injections. So you can see that the volume was not sustained, so then she was injected with PLLA, and at 72, 1 year after the third session of PLLA. Here also we have this patient, 60 years old, before facelift and fat grafting. In the middle, 64, 2.5 years after the facelift and the fat grafting, and before PLLA. And then at 70, 6.5 years after having had 4 sessions of PLLA. So the results have very, very long term. Now, a lot of, again, talk about the fact that don't use PLLA, it will create a lot of volume, you cannot control the volume. It all depends on the treatment strategy and the treatment protocol. There are basically 2 ways to use PLLA. One, simply for skin rejuvenation, whereby the total volume which is suspended is injected panfacially in the lateral face, or where you have focuses of treatment in certain areas that require volume. So it depends on the practitioner, and it depends on each individual patient's requirement. So if we see, I have some photos of patients, this is before and 2 years after 5 vials of PLLA, without excess volume, just for skin quality. Here also, look at the skin quality before and after 6 vials, but the patient was 89 years old. So you can do it in a certain way just to get improvement in skin tone and texture, or, and again in this case, 37-year-old patient who had lost 10 kilos in 9 weeks. So here you don't see any increase in volume in any one part of the face, but you will see her on animation, you can tell the improvement in firmness of the skin. You can see that when we looked at volume in her face, she had 3.7 cc's in the whole lateral face. So the volume was distributed evenly everywhere, perhaps just giving her skin thickening. And this is her smiling before. She had like accordion lines all the way lateral to the oral commissures. Then the second picture after 4 vials, once we finished the course. But however, the final result is actually 1 year after the course of treatment, at least. And then 1 year, and following the 4 sessions, which is the initial course, according to her age, the patient had 1 maintenance vial every year thereafter. And now she's even better than she was 3.5 years ago. So you can see her before and after. And of course, this is one way we can also assess skin firmness by the pull test. However, sometimes we need to restore volume, like in our weight loss patients, like people who want more zygomatic, let's say, enhancement. So this is, again, another patient. You can see her before and after. What you can note is that there's a change in her facial shape. So before, she was not symmetrical. She was not the ideal oval, which we know is the indication of female beauty. So in this case, it was treated differently. She was injected more. She had some pan-facial injections on the side for firmness, but the focus was the zygomatic arch, and more on the left than the right. The volume was more left and right. And you can see she created volume. This is her own tissue, soft tissue, less on the left, right, and more on the left. So this ended up with her looking oval. Here again, patient had more of a long face without lateral volume, so we focused on the lateral areas, and you have significant volume being deposited. This is my last case. You can see she had significant hollowing in the submalar area, and by the way, this is an area where we are very cautious, especially in women. We do not want to overinflate.
You have 1 minute.
Yeah. You can see her here before and after 2 sessions only. When she came for her 3rd, she was 53, so she would have normally required more sessions. When she came for her 3rd, I totally refused to inject the submalar area. And you can see here 1.2 cc of her own soft tissue on either side being developed with time. So really, PLLA can help us to prevent skin laxity, to actually lift the skin, induce volume for those areas that require volume, and gives us very long-lasting results. It should be, again, integral to any regenerative anti-aging practice. Thank you.
Thank you, Dr. Maria.
Now, Dr. Hassan Kardari. Dr. Hassan Kardari, American Board Certified Graduate of Boston University, Dermatology Program in USA. He is currently an Associate Professor of Dermatology at the College of Medicine and Health Science of United Arab Emirates. He has lectured in numerous international congress, published in many journals, Sarah's book chapter, as well as best-selling book, Soft Tissue Augmentation Principle and Practice, which was translated into many languages, Turkish, Spanish, and Chinese. Welcome, Doctor.
Thank you. Assalamu alaikum jamia. Thank you, Dr. Muhammad, for the kind invitation. Thank you for all the organizers for the wonderful hosting of the event. So I'm going to go right through it because, we're short on time, and it seems the chair people are very strict when it comes to timing, so I got to make sure that we finish right on time, and I do have a few slides. These are my little disclosures. There are no conflicts of interest. As you can see here, I am involved with all the usual suspects. I do have, as was mentioned earlier, a little small, I don't want to call it a textbook, but a little small handbook on soft tissue augmentation. So whatever it is that I talk about is usually that's been published over there. So for the objectives for today is that we're going to talk about the components of the skin initially at first, and then we're going to move on to biostimulation, and mainly biostimulation through the uses of injectables, because that's what I'm notorious for. The building blocks of the dermis, of course, as you probably might know, if you look at all the different pictures over here on what you're seeing, the first one is made up of hyaluron. Hyaluronic acid is your glycosaminoglycan. It is a sugar. It is able to absorb water. It is able to hydrate your tissue. That's how it tends to work. Then you have the one next to it is a protein. This is your collagen. Now, collagen pretty much is it gives you the structural effect of the skin. And at the same time, as we kind of get a little bit more mature, we start losing a little bit of the collagen. So by the age of 25, every year we're going to start losing about 1%. And finally, that looks like elastic fibers is your elastin. And this pretty much gives you your elasticity and at the same time your stretchability. As you can see over here, as we get a little older or more mature, these components of the dermis tend to become less and less. And initially, they don't seem to appear in the beginning, but then once you start hitting your 30s, that's when things start going downhill. So anybody here who is over 30? I guess everybody's over 30. Yes. Hopefully nobody's in their 20s here. Even though I have to say, Maria looks, probably 26. She has not changed. I've been giving talks for over the past 17, 18 years, and I've known her since then, and she has not changed whatsoever. So that's, this is what usually tends to happen. And basically, once we start our 40s, that's when we actively try to kind of make sure that our bodies kind of retain these structural components through the effect of biostimulation. So how do we do that? First of all, we have to understand what biostimulation is all about. Biostimulation is simply the ability, or basically what we tend to do to the dermis that allows pretty much the fibroblasts to perform their effect. And we're able to do this through many different ways. It can either be through a direct damage, and it's, when I say damage, it's usually good damage, and this is usually through the effect of our energy-based devices, or it could be through injectables such as fillers or possibly neuromodulators. So let's talk a little bit about the injectables. And I understand from the past two talks, the injectables or parts of the injectables were mentioned. And I attended a few minutes of Maria's talk, and she mentions polylactic acid. So the way that they tend to work, any of the injectables, is that if they are injected, or once they are injected, they're able to elicit a foreign body response. And this is a controlled foreign body response. And that's how they tend to work. They can either fill and at the same time elicit that through the effect of on the fibroblasts. So what we did is that we looked at the literature. This is a paper that was published a few years ago that kind of evaluated the biostimulatory effects of all the different fillers that were out there, or the biostimulators that were out there. We looked at polylactic acid, polycaprolactone, calcium hydroxylapatite, and also hyaluronic acid, because we always thought that HA was just an inert filler. So we wanted to kind of see if the literature actually approves this or not. This is how they look like. So this is your famous brands that are out there, your PCL, your CAHA, and at the same time your polylactic acid. And if you look at them under the microscope, this is how they tend to look like. You can see the PLLA with its jaggedy edges, the PCL with its more round spherical effect, the CAHA is also about the same, and at the same time you're able to see the HA. The HA also has a little bit of, they're made up of, I don't want to call them microspheres, but they're made up of particles, and some of these particles are also jaggedy edged. First of all, let's look at the polylactic acid. I'm going to move very quickly because, Maria did a fantastic job there, so I'm not going to ruin it for you. Okay, but this is how it tends to work. So once the PLLA is injected, the particles, the PLLA particles are able to stimulate pretty much the effect of fibroblasts. They're able to do this through directly, either on the fibroblast itself or indirectly through the effect of macrophages. Macrophages come in, they start engulfing the PLLA particles, they produce their cytokines, and you saw that she listed all of them on that table, and that effect pretty much causes the collagen to be produced in the dermis. How does it compare? So this is basically if you look at the comparisons between all the different particles according to this article, when it comes to biostimulation of collagen, you have PCL, you have PLLA, you have PDO. You see that the most robust one actually is PCL. So polycaprolactone really produces the most robust type of collagen biostimulation when compared to your PDO and also your PLLA. Now, it doesn't mean that it's bad or good. It just tells you that there's a little bit more of a robust reaction with PCL as compared to the others. Calcium hydroxylapatite also does the exact same thing, and the effect of calcium hydroxylapatite lasts for a long period of time. I've had a patient who's been injected with calcium hydroxylapatite for many years, then she stopped. 4 or 5 years later, she comes back to me, she looks deflated. She does not have, any volume. And I insert my cannula, because I usually tend to use cannulas, and the cannula refuses to budge. There's just a lot of fibrous tissue that is there. So this kind of tells you that the longevity of these products can be sustained for a long period of time. Now, calcium hydroxylapatite, of course, can be utilized for many different ways, and you're able to see it over here through the effect of ultrasound thickness of the dermis. It is different, especially in the areas of the neck. Calcium hydroxylapatite has become very, very popular these days because you can also not just use it in its pure form, but you can also hyperdilute it. You do so by diluting it either as a 1-to-1, so it comes in a 1.5 syringe, you put in 1.5 of your saline or your lidocaine, or you hyperdilute it, so it becomes 1-to-2 or 1-to-3, depending on the area of injection. And you can also utilize it in a process known as skin priming. So skin priming simply means that you're not just diluting it with your saline or your lidocaine, but you're also adding a little bit of something different, which is, in this case over here, is NCTF. So NCTF is a cocktail of HA, glutathione, vitamins, polynucleotides. It is combined with the calcium hydroxylapatite in a hyperdilute form and then injected, and then basically it gives off pretty much a much more robust biostimulatory effect. And this is how it tends to look like. Let me see if I can play the video. And you're able to kind of see the difference. So this is, your NCTF, which looks like a little bit more on the pinkish side. Your calcium hydroxylapatite is over there. And what we tend to do is that we try to kind of combine them together. So we bring them together and we kind of, let me see, moving forward. It doesn't move that fast. Okay, I'm sorry. And you just basically switch them together using a female-to-female connector, which you're able to see there on your upper right-hand side. And then you inject it. It's a simple injection, and the way that you do so is that you basically have to inject it very superficially, so you're doing it in the superficial fat compartments because you want to make sure that the material that's injected is very much close to the dermis. You're not in the dermis because your cannula doesn't go through the dermis. You're very close to the dermis, and that's the area in which you would want to inject to kind of give you a much more robust reaction and a much better effect, clinical effect for your patients. And this is basically how it is injected. All right, perfect. And the results, according to the study that was published in the JDD, you're able to see that on ultrasound, the dermis is slightly thicker. And you can see here clinically also the results are visible. Now, what about HA? and in the last 5 minutes, I want to talk to you a little bit about HA. Now, historically, HA has always been considered to be an inert filler. It is a filler that we just inject, and it's just going to give you a volume. However, we've also realized, according to many studies in the past, especially in 2007, that the effect of HA can have something of, an effect on the fibroblast. There is some mechanical stretching that occurs in the fibroblast that allows the activation of the fibroblast to produce collagen. As a matter of fact, this is what we thought to be there initially, and this is how it tends to look like on a histological slide. You see, once the HA is injected, there is the formation of collagen because it is through the effect of that mechanical stretching. Now, HA in itself, if it's re-injected multiple times, can have an effect on the fibroblasts themselves, and it depends on the size of the HA, because the HA itself comes in different sizes. You have high molecular weight and also low molecular weight. The magic weight is about 200 kilodalton. The 200 kilodalton HA is able to directly stimulate fibroblasts to produce your own collagen, and hence the term skin boosters. And a number of skin boosters do exist in the armamentarium. These are little examples. Like I said, there's no conflict of interest here, okay? But you can see them over there. You have your Restylane Vital, your Profilo, your Jalapro, your Juvederm Volite or SkinVive. Belotero also has Revive Teoxane Redensity 1, and the last one here is your Hyal System Duo. So this is basically your your HA. So HA does affect the fibroblast. However, the effect does not last that long. All right, so in conclusions, PLLA induces collagen. There is an inflammatory response. PCL induces collagen. However, the publications are a little bit more conflicting. It definitely causes volumization though, however. Calcium hydroxylapatite induces collagen, and the effect is very much robust in the first month, and then after that, 50% of it is lost. And then, of course, your HA is able to do that because it also enhances the thickness. HA has been very close in the limelight recently because if there was a recent person who had an MRI, and 12 years after her being injected, her HA was still there. Okay, so it kind of tells you that HA is, we thought that it goes away very quickly. As a matter of fact, it can stay there for a long period of time. Now, the last thing that I want to touch about, of course, is your botulinum toxin. Is botulinum toxin, biostimulatory? And I have to tell you that it is not. Okay, so botulinum toxin does not cause any form of biostimulation. It does not affect your fibroblast. As a matter of fact, your collagen production after the injection of botulinum toxin does not do anything pretty much on the effect of this. That being said, a lot of people say, once I inject my forehead, I have that little shine. Where is this shine coming from? The shine is explained through the effect of the following. Because your wrinkle starts becoming a little bit more wider, the reflection of the light happens, and hence the reason why it starts to shine even better. So that's where the shine is, okay? So the shine is not due to the effect of the collagen production. And as you can see over here, whether it's collagen type 1, type 3, and also with the elastin fibers, botulinum toxin does not cause any form of biostimulation. Now, that being said, botulinum toxin can also be injected very superficially in what is known as microtox, or which is an intradermal injection with a very small little aliquots that was made famous many years ago by Dr. Waffles Wu out of Singapore. And that pretty much the whole point of this is that what you're trying to do is that you're trying to kind of relax the superficial muscles in addition to basically the components of that part of the skin to cause a decrease in vascularity, decrease in pore size because you're decreasing secretions, and at the same time also decreasing in sweating. Okay, and this is basically the injection technique. So you can look at this, basically covers the whole part, and these little small aliquots cover the whole face. And as I mentioned, the indications would include acne, rosacea, oily skin, and enlarged pores. And you see here the effect of botulinum toxin on the skin. There is definitely a decrease in vasculature, okay, after it is injected. I've started using it for rosacea, and I have to say my rosacea patients tend to like it pretty much. And, at the same time, you can also decrease in pores. So I thought of something that's, I consider, I don't want to call it a secret because I've been telling it for everybody, but why not reconstitute your botulinum toxin, not with saline, but reconstitute it with one of the mesotherapy cocktails that we tend to use, which is NCTF. So this is what I tend to do. I take in my 100-unit vial of botulinum toxin, whichever it is, whether it's Xeomin or whether it's Botox or whether it's Nabota or anything, and then I would add in my I would add in 5 ml of my NCTF, and then I would inject it very, very superficially. As you can see here, it's extremely superficial, covering the whole part of the face. So I'll cover basically the forehead, cover the eyes, and you can see here I'm basically injecting it pretty much haphazardly, but making sure that it is superficial. You have to be superficial. If you go deep, you're definitely going to cause issues and problems for your patients. And this is a mixture of 100 units of botulinum toxin with 5 ml of your NCTF injected very superficially to kind of give off a dual effect of the effect of your mesotherapy cocktail on the effect of fibroblasts to give you that luminosity in addition to your botulinum toxin. And pretty much this is the results. As you can see over here, your before and afters. Okay, she looks natural. She's able to move, and at the same time, she also appears a little bit lighter. I'll finish. And this is how she looks like on her neck. You can also inject it on the neck. I apologize for the quality of the skin, the picture over there. So biostimulation has to be a combination. Okay, you have to combine both your injectables, your energy-based devices, your skincare products. All of this have to be coming together to get the best results. And with this, I'd like to thank you for your kind attention, invite you to the International Congress of Dermatology. I know Giovanni Pellicani is here because I had him over at my home 2 days ago for dinner. So he is here. So please make your way to Rome, and also make your way to Guadalajara, Mexico for the World Congress. And as you probably all know, Dubai is bidding for the World Congress of Dermatology for 2031. Please speak. There's Lydia Rudnika who's here. She's a voting member. So Dr. Mohammed, please talk to her so that she can vote for us. Thanks again for your kind attention.
Thank you, Dr. Hassan, for the excellent presentation. Next is Dr. Mustafa Narwan. He is German board certified plastic and aesthetic surgeon with extensive international training and expertise. He earned his medical degree in Germany, Switzerland, and USA, passed the USMLE and received PhD in cancer immunology with a magna cum laude distinction. Dr. Narwan completed his residency in plastic surgery and fellowship in aesthetic surgery in a prestigious German institution, including University Clinic in Erlangen and Kassel, under professors, and he further enhanced his skills through advanced training programs, global conferences, and mentorship to top institutions like Stanford, and with esteemed surgeons like Dr. Mendelsohn in Melbourne. Dr. Narwan is full member of several prestigious German and international associations, including the American Society of Plastic Surgeons, a distinction held by few German plastic surgeons. Dr. Narwan will present today micro-coring, a breakthrough in facial skin tightening. The stage is yours.
Thank you very much. Thank you very much for the kind introduction. Welcome. Thank you very much to the organizers for inviting me. It's a great pleasure to be here in front of experts, dermatology experts, and to talk about micro-coring today. Well, I personally am a German board-certified plastic surgeon, now based in Dubai, and today my presentation is about micro-coring to tighten the skin. I do not have any conflict of interest, and when I do my treatment, I'm a big fan of a holistic concept. What does holistic mean? That means combining different treatments, devices, products, maybe also surgeries to get the best possible solution for our patients. Because not everything can be solved only with one treatment. Different targets need different devices. Different goals need different devices. We have non-invasive options, which is, for example, skincare. We have devices like lasers, and we have the more invasive, which are injectables, threads, or maybe also surgeries. And the micro-coring is something in between the minimal invasive and the full invasive treatment. So the device that we use for the micro-coring in our clinic is the ELACOR. The ELACOR had about 14 studies from the year 2014 to 2021, and a pivotal study was done 2019 to 2020, and it was FDA approved by July 21. So what can be targeted? The skin wrinkles by itself. So we have the degradation, the Lempel Wrinkle Severity Scale. By the way, this is Professor Lemperle. He is a German board-certified plastic surgeon. He's one of the pioneers in plastic surgery, and he's my motivator and inspirator to become a plastic surgeon. So I did a part of my med school back in the days at UCSD and San Diego with him, and he created this Lemperle Wrinkle Severity Scale. So it's from 0 to 5, that means no wrinkles, just a little superficial wrinkles, then more severe wrinkles, deep and very deep wrinkles. And these wrinkles can be treated with the microcoring system. So the indication of use is moderate to severe wrinkles for the lower part, the lower third of the face, that means the mid face, for Fitzpatrick skin types 1 to 4. It's important that to have the medical history of the patients, that they do not have any other illnesses or take any medications, which are contraindications. I will tell you something about that later on. And of course, it's important while you do the treatment that you do not put any other topical products which can be introduced into the skin. So, what is microcoring? Microcoring is pinching out or stamping really the skin out. That means it's not needling as we know it from radiofrequency microneedling, where we just perfect the skin. It's really punching out the skin. And the diameters of each punch is less than 0.5 millimeters. If you go bigger, then there is a high risk that you create scars afterwards. So it should be not too big. And it's important that you really punch through the whole skin, the epidermis and the dermis. If you're too superficial, you would not get the result. That means you need also a vacuum system. So you pinch, you cut the skin, and then you suck it out. So you have really to open the full thickness skin, and rapidly the skin gets together and closes the gaps. So we talked about biostimulation. Well, more or less everything is biostimulation, what we're doing at the face. Not Botox, but everything else, the products that we inject, the fillers because of the force, the PLLAs or calcium hydroxyapatite, but also the energy-based devices. All of them are biostimulators. That means we stimulate our own body to heal, and this is biostimulation. And what is the difference when we do the microcoring to all the other existing technologies? Well, we are damaging, of course, because we are punching out the skin, but we are not creating a thermal injury, which is done, for example, with RF microneedling, with lasers, or with high-frequency ultrasound. We are not creating heat, we are just removing the skin. So, before the treatment, of course, the clinical assessment is very important to analyze the skin. Do we have really the right indication for the treatment? So for those who are too young or too old, they are not the right candidates for these treatments. The medical history is important. Do they have any other illnesses which are contraindications of the treatment? Of course, we have to set the right expectations before we do the treatments. And it's important that you communicate all those things before you start with the treatments with your patients. Set the right expectations, tell them exactly what we can expect from the procedure, and prepare the patients for the aftercare. Because it's not like Botox treatment or just a filler treatment that they can have some little swellings. It's more invasive. Of course, it's not like a facelift, but you have to tell them before that they will have redness, that they will have swellings, that you will also have some bruises. And it's important that you tell it to them before you do the treatment. Otherwise, when you do it afterwards, it's an excuse. You have to inform them before. The contraindications, well, if they have any dermatosis, above bony structures, the treatment should be avoided in the mucosa membrane, and if you have any silicone or synthetic materials implanted under the treatment area, it should be avoided. Of course, not for pregnant people, not for wound areas, and the patient should not have any allergies to steel and to all the products that we use for cleaning, prepping the face, and also for the tumescent solution that we have to inject before doing the treatment. Moreover, they should not have any bleeding disorders. dermatologic and autoimmune conditions, and a surgery should not be done in the area about 12 months ago, and also other minimally invasive treatments should not be done 6 months before the treatment, and of course they should not have any systemic or local infections. No blood thinners, in case they have to take it, they should stop, and of course no chemotherapy, radiation, or high-dose cortisone therapies in the treated area. So how should we treat? Before starting with the procedure, we have to numb the area. We use a tumescent solution. It's for making the procedure more comfortable for the patients and also to reduce the bleedings. And the tumescent solution that I use is containing sodium, bicarbonate, lidocaine, and epinephrine to reduce the bleedings. What can we adjust? We can adjust the depth of the punches depending on the skin quality, and also we can adjust the amount of punches that we want to create. So with the Elacroix system, each pattern is 1 by 1 centimeter, and we can adjust that. We say, okay, I would like to punch 1%, which would be 9 punches in 1 square, or we can increase up to 8%. That means 60 cores in 1 by 1 centimeter square. And we can change the depth from 0 to 4 millimeters. Depending on which part of the face we treat, the more soft tissue coverage we have, the deeper we can go. And of course, it depends also on the skin quality. If the skin is very, very thin, of course, we should avoid to go too deep. In bony structures, we have to go lower with the depth. In the mid-cheek area, we can go higher, and perioral, again, more superficial. As I said, it's important that you punch really the epidermis and the dermis, and this is how it should look. This is a nice example. You see all the pores, you see little bleedings, and they're all equal. If the bleeding is not equal, then the punches were not done correctly. So in some parts, maybe in the right layer, in some not in the right layer. So it's important that you really see the course. I use glasses while I'm doing that to really to see that I have removed the skin. Before starting to do it on patients, of course, it's a handling part. It's important that you really have a 90-degree angle to perforate the skin. You should test it on papers first. And it's important that you make the little squares very close to each other, but no overlapping. Because when you overlap, then you would remove too much skin in one part, and then you would create bigger wounds, and that can cause scarring. So it's important to keep it as close as possible, the gaps, but no overlapping. Very important. So this tumescent solution, as I said, saline, lidocaine, bicarbonate, and epinephrine. And it's important to inject pretty superficial. If you inject too deep, then the numbness could not be proper. But more importantly, the vasoconstriction is very important. So that means the vasoconstriction of the superficial veins should be targeted. Therefore, the injection should be pretty superficial. And after the injection, the skin should become a little whitish. Here I injected only the right side. It was, in this case, 40 cc. You can go up to 50 cc per face side. With a blunt cannula in a fanning technique. And of course, after the injection, you should wait really to see also the effect of especially the epinephrine. And then the treatment by itself. I do it with my magnificent glasses to see that I'm really punching the skin out. And you need an assistant that every time you do that to swab away the skin that you have removed. So placing it 90 degree, punching out, sucking out, and then wiping it up. The post-procedure. For the post-procedure, I recommend to the patients to gently wash their faces just with water twice a day, to use healing ointments that they can also use twice a day for about 7 days. And once the cores are closed, to use SFP 30+. I would recommend even to go higher. And sun protection, of course, is very, very important during the healing process. the same case, this lady, that was her before situation. 1 week after, you still can see it, and also even 2 weeks after. In her case, it was visible. But she was very sensitive. So it doesn't mean that it's like this for every patient. So some patients, even after 2-3 days, you cannot see something, but it can happen that still after a few weeks, you see the little pores, and you have to inform your patients, right? Otherwise, they will be scared afterwards. You have to tell them this can happen, that it's visible for a long time.
3 minutes more.
Thank you. So that was immediately after the treatment. You see the punches, each of them are open, and this is the same lady now about 3 months ago. She sent us her photos. Let's go through a few cases. So the target is mainly the jowling area, and I focus on the accordion lines. And as you can see, a nice improvement for this lady. Even for the more mature or older ladies, it's a nice device to tighten the skin. This is one of our patients done by Dr. Danny Tuma. You see here very nice improvement, especially when we focus on the nasolabial fold and also of the prejowl sulcus and the jowls. We see a nice improvement because the whole skin in the lateral part of the face tightens, and that creates, of course, also lifting. When we do facelifts, we pull not just the skin, we go to the deep layers. That means the SMAS, it's a deep SMAS facelift, because we do not want to create all the force just on the skin. That would create big scars. But when we do the treatment with microcoring, we target just the skin, not the deep layers, not the SMAS. So that means we get a nice skin tightening, and the benefit in compared to the facelift, we don't create scars and not such a long downtime. Thank you very much.
And are the effects cumulative for it?
Right. You can repeat it up to 3 times, depending on what you want to achieve. And you should wait, I would recommend around 2 months, because you want to see what you have achieved with your last treatment. And it's also like a biostimulator. That means we stimulate the body to produce collagen, elastin, and that needs time, minimum 2 months. So I would recommend to wait up to 2 months until you repeat it, and you can do it up to 3 times.
Thank you so much.
You're welcome.
Any other questions? Yeah, there is a question from Dr. Paula.
Thank you, everyone, for this excellent presentation. I have 2 questions. One is for Dr. Maria. Now we have where we can do PLLA with energy devices. What is your recommendation on that? They're saying that you can do the energy device first, and then you can do the PLLA second. That's number 1. And then number 2 for Dr. Galadari, using the 100 units of Botox, how soon can you do another treatment? And is there any risk of resistance with using this amount of Botox?
Yeah, regarding PLLA and energy-based devices, actually they can be used simultaneously. And in fact, it's been published looking at transdermal delivery of PLLA after fractional ablative CO2 laser with very good results. So the PLLA is not going to be degraded by the energy-based device. So you can do it before, you can do it after, depending on the case, you can do it at the same time. In fact, actually, our protocol for atrophic acne scars is to use an ablative fractional device and either inject, or some people apply topical PLLA. We actually inject it at the same time.
Yes, so that's a great question with regard to, so I'm going to repeat the question for anybody who has not heard it. How soon do you repeat the microtox if you're going to be using a total of 100 units? There is a talk, I usually give a talk on microtox that's completely on its, as a standalone, and I mentioned the adverse events. This one here, it was on more biostimulation, so I did not. But you're absolutely correct. So we should not repeat the treatment as frequent as, you know, the thing that we're usually used to. So my recommendation here is to kind of space it out. You're able to do it the way that you're able to do your botulinum toxin, so it's about anywhere between 3 to 4 months. Now that being said, microtox, the adverse events, let's put it this way, the adverse events can have, in the initial phase, a little bit more of a frozen look, okay, so in the beginning, and at the same time, you can also, if injected incorrectly, can cause, you know, complications such as ptosis, eyebrow ptosis, or even eyelid ptosis, but that's not toxin related, it's pretty much injector related. Also, the effect does not last as long, okay, because you're injecting it very, very superficially. Okay, it's not really getting into the muscle, you're mainly injecting the dermis. It's gonna last you anywhere between 6 to 8 weeks. But that being said, since you're injecting a total of 100 units, you still have to wait a good 3 months before re-injection, because if you do it too frequently, you are gonna run the risk of developing, you know, antibodies and then resistance to it. So yes, this is a little bit of a downside of it.
One more question from Dr. Touma.
Great session, thank you, everybody. Question to Dr. Maria and Dr. Hassan on the biostimulators. I've seen some conflicting information. Dr. Maria, you know, showed some concerning results about calcium hydroxyapatite on the long term. Dr. Hassan seems to like it more. You know, and you know, we kind of put them in the same category. My preference is for PLLA, although I'm not a big user. I'm concerned with, you know, the kind of the uncontrolled, you know, events that happen over time, and you can't really control the volume as you mentioned, but I'm sure with experience you can do that. So the question is, you know, what's the final point on calcium hydroxyapatite, and how do you use them on body areas, neck, you know, butt, other areas, and a comment on Elacor. Dr. Narwan gave a great talk. It's still in the beginning. The coring punches are getting smaller, so the healing will get better. Obviously, we've come a long way from CO2 resurfacing to almost no healing time to back healing time, but I think it really fits in our a nice niche in our practice where we get nice tightening and slimming of the face, while all the biostimulators tend to give more volume and squaring of the face if overdone, or maybe over reactions from our patients, or if they gain weight. This achieves a nice slimmer face, which I think a lot of people would prefer. And the point on body treatments with Elacor, it's still in the works, but it seems to hold a lot of promise for neck, for breast, for all body areas. But it's still early. We will see with time. Very promising.
Did you want to comment? Well, I mean, I have to admit, you're one of the first people who've used calcium hydroxyapatite. So I mean, you can talk a little bit more about both of them.
Yes. In my experience, there's never been overcorrection. Okay. Again, it depends how it's done. If you're cautious, if you space the treatments far apart, if you undertreat. In fact, my model, which I showed, is sitting here now after almost 3.5 years. There's absolutely no evidence of any overcorrection, but incredible firming. We each have our own preferred, biostimulant, but the evidence now is more and more about the regenerative potential of PLLA over and above biostimulation. For us, biostimulation mainly means collagen, full stop. But the evidence is showing us about stimulation of the dermal white adipocyte tissue, the subcutaneous white adipocyte tissue. Now we have a different angle, the effect on elastin, which is proven. So it's over and above simple biostimulation, as far as I'm concerned. And I think they're each in their own right a good tool to have, and it depends at the end of the day on your experience. Right, Dr. Hassan?
I would agree. I've stopped using calcium hydroxyapatite in its pure form. Now all I do it is usually through the effect of either diluted or hyperdilute. And the way that I dilute it is with NCTF. As a matter of fact, I have it injected on my face. Okay, so there's a little bit of a conflict there. So that's my little disclosure. So I feel that whatever it is that I'm going to be doing to me, I would also do it to my family members and also my, my friends and, patients. So I personally, I like the fact calcium hydroxylapatite, I'm able to kind of move around in terms of its dilution. I can soften it up, I can harden it, depending on the area of the body that needs to be injected. There is more evidence in terms of calcium hydroxylapatite in terms of the publications. Also, there is also more evidence for the body. You mentioned the body, so there is, you can definitely utilize it. There's publications by myself in the neck. There's a little bit on the knees, so calcium hydroxylapatite can be utilized into that area in its hyperdilute form. So in terms of publications, you have them both. I think you have to kind of critique those publications and do what's best for your patients at the end of the day.
Also one add-on as a plastic surgeon, because maybe you were confronted with it, that a lot of plastic surgeons say when they do afterwards, for example, facelift for patients who had overdone treatments with biostimulators, with fillers, then the surgery is challenging, could be challenging. So the problem that we challenge when we do the facelift, for example, if required afterwards, it's not the biostimulation where we get collagen stimulation, it's the inflammation that starts during the treatment. And here when you compare PLLA with calcium hydroxyapatite, the PLLA is causing more inflammation as a product when you look at the science compared to calcium hydroxyapatite. But it's not just product related, because an inflammation happens also in the way how you deliver, for example. So if you do it in a very radical way and you create a lot of wounds with your cannula, for example, and you repeat it on a very regular period of time, you cause wounds, you cause inflammation, and you cause fibrosis. As you said, even after years, when you do your injections, it's very difficult for you to enter. But this is something that we do not want to create. I mean, it feels nice because it's tight, but it's fibrosis. It's damaged tissue. We don't want to damage, right? So the way how we deliver, the way how we dilute also, dilute it more, not to have too much product just in one space. Avoid to repeat too often and try to apply the product, the biostimulators, as equal as possible.
The last question.
We're done. I'm sorry, we're done, but just one question. We know that it's contraindicated to use a biostimulator on autoimmune disease. Would you inject polylactic acid on patients with history of or diagnosed with autoimmune disease?
That's a great question. As a matter of fact, I'm going to take you to two wonderful JAD articles that were published a few years ago in the Blue Journal, and there were CME articles that looks at this for the treatment of patients with systemic lupus, and at the same time for patients who had systemic sclerosis and morphea. And they talk about all the different types of fillers in which you are able to inject. From all of them, the safest one that they've mentioned is HA. So HA can be utilized for patients with lupus. Of course, you have to take the green light from the rheumatologist at the end of the day. But that article really kind of displays the polylactic acid, the Me?
Hyaluronic acid,
So, I mean, according to the... Yeah, according to the article, you can. Yeah, you can. And polylactic acid actually works very well as a scaffold to the adipose tissue. So if you are going to be injecting, for example, fat, and you also combine it with polylactic acid, it acts as a scaffold and makes it even work better. That's according to the article that was published.
Thank you.
Thank you very much. This is a very informative discussion. A discussion about this topic is endless, so we have to stop now. Maybe we can have more discussion with the presenters during the coffee break. Thank you very much.